Hi, everyone. It's really great to be here today. My name is James. They said, I'm a second-year medical student at the University of Vermont. I grew up outside of Cleveland, Ohio. And today I'm going to give an overview on our research program at the Boston Lymphatic Center. And I thought that the best way I could do that was to just walk through some exemplary research projects that I think really demonstrate where our attention is as a research team. And so I want to give a little bit of background on me. My father's an oncologist. My mother's a hospice nurse. And so growing up, for better or for worse, cancer, death, all those things were like daily conversations. They were dinner table conversations. And every year, my dad's, the cancer center where my dad worked would put on oncology on canvas shows from Lilly Oncology. And before I understood what chemotherapy was, breast cancer, lymphedema, I was, 10, 12, 14 years old, seeing these really moving images of women, these, artworks that really, I thought just like really demonstrated to me the impact of going through breast cancer. And I think when I, every day work with patients who come in who've had a prior history of breast cancer, when I sit in on lymphatic conferences of lymphedema patients, I see patients who are really strong and resilient, and I see patients who are going through change. And that change is really difficult. Lymphedema is chronic, but change can be beautiful. And I see a lot of strength in those patients. And so it's a huge privilege to be able to do research with this patient group. Okay, and my own one disclosure is just that I'm the recipient of the JOPES Lymphatic Research Grant. So today I'm going to start by giving a background on where our attention is as a research group. I'm going to walk through several key areas of research and just talk through some projects that highlight those areas of research. Kathy Schlew, one of our lymphedema therapists, will also come up and present a project. And then our two amazing research coordinators, Angela Chen and Stephanie Zovich, will come up to talk about our R01 and U54 grants. Okay, so a little bit of background. Our group has a very strong conviction that variations of upper extremity lymphatic anatomy are an under-recognized risk factor of breast cancer-related lymphedema. And we're really interested in so-called compensatory or backup routes of lymphatic drainage. Routes of lymphatic drainage from the arm that terminate to lymph node groups that are not damaged during an axillary lymph node dissection. And two of those two major pathways are the lateral upper arm pathway, as well as the tricipital or posterior upper arm pathway. And so past research fellows, Anna Rose Johnson, Melissa Granoff, Rosie Friedman, have all described in great detail variations of this lymphatic anatomy that exists at a population level. Now, why are we interested in these lymph node these lymphatic pathways? As I said, these pathways have been described, some of them, especially the lateral upper arm pathway, for several hundred years in very early anatomic works. These pathways have been theorized to drain or terminate to lymph node groups that are not dissected or damaged during surgical treatment for breast cancer. And so we believe that variations of this pathway are going to allow a patient to continue draining their upper extremity lymphatic system despite an axillary lymph node dissection. So the lateral upper arm pathway, or Mascagni-Sappi pathway, drains to the deltopectoral lymph nodes, and the tricipital or posterior upper arm pathway drains to the subscapular, posterior axillary lymph nodes. Now, having this pathway is not necessarily protective. It's not black or white, it's shades of gray. So these pathways exist in different phenotypes. So a short bundle is just present in the upper arm. A long bundle is present in the entirety of the arm. So when a patient with a long bundle of this lateral upper arm pathway or tricipital pathway, the entire forearm can reroute drainage to this backup pathway. But these pathways also terminate in different sites. So in 90% of patients, the lateral upper arm pathway or the Mascagni-Sappi pathway will terminate in the deltopectoral region. In 10% of patients, it's still going to terminate in axillary lymph nodes. And in those 10% of patients, that termination to those lymph nodes that are damaged during an axillary lymph node dissection might mean that that's not as protective. Rosie Friedman, our past research fellow, about a year ago described the tricipital or posterior upper arm pathway, and in about 50% of patients, that pathway terminates, we believe, in the subscapular lymph nodes, and we think that's protective. In a large number of patients, however, it connects to the medial pathway that still drains to axillary lymph nodes. So those patients, that pathway is protected, but it's still draining to lymph nodes that would be damaged. So again, there's shades of gray here about whether it's a short bundle, long bundle, but also where the pathways terminate. So I'm going to walk through now some key areas of research. I'm going to start with lymphatic anatomy and where my focus has been. The first project has come from our R01 grant. And this is a project by Rosie Friedman that I was able to help with when I started my research fellowship in March of 2023. And in this project, we demonstrate that lymphatic anatomy is not symmetrical between the right and the left upper extremities. So in July of 2022, we read a paper, the group read a paper, and this was prior to my time on the team, in which the authors had a patient with unilateral lymphedema, and they used the unaffected contralateral arm as a mirror image of the affected lymphedematous extremity. And anecdotally, we had observed on ICG lymphography that patients often demonstrate asymmetry in their ICG lymphography. And so the team felt compelled to write and say, we don't know if this assumption is correct. Anecdotally, we don't always see that. So a lot of amazing work has been done by contemporary lymphatic anatomists like Haru Swami from the ALERT team. However, no one's really demonstrated whether that lymphatic anatomy is symmetric between the right and the left extremities. Now, in terms of functional drainage patterns, meaning lymph nodes that drain the arm, Hayley Reynolds is a PhD at the Auckland Bioengineering Institute in New Zealand. This is a paper that came from her PhD thesis, in which she demonstrated that at a population level, there is symmetry between the right and the left arms in terms of the lymph nodes that drain the arm, but this paper didn't look at ICG lymphography and the actual pathways. More recently, though, smaller studies have suggested that there is asymmetry in the functional drainage between the right and left extremities. So there's conflicting evidence about whether there is symmetry in the function of the right and the left extremities. So the problem is that this assumption of symmetry is not just a theoretical assumption. It's actually now extended into clinical practice. So in this paper, this is a case report and published in Plastic and Reconstructive Surgery Global Open. In this paper, the authors were planning a lymphovenous bypass to treat a patient with unilateral breast cancer-related lymphedema, and they used the unaffected contralateral arm to plant incision sites on the affected arm. So if asymmetry does exist between the right and left arms, you're making incisions where there might not be a lymphatic vessel. So this assumption of symmetry can maybe create undue or unnecessary incision sites. It might need to abort a surgery. So seeing that this assumption is now extending into how surgeons are planning lymphatic surgeries, we felt the need to really demonstrate whether this symmetry exists. So I want to introduce our R01 grant, because this is where a lot of our attention is as a research team. Our R01 grant is mapping and quantifying lymphatic drainage of the arm's alternative pathways. In this grant, we are recruiting 100 healthy female volunteers, as well as 40 women, our AIM2 patients who have had a prior axillary lymph node dissection for treatment of breast cancer but who did not develop breast cancer-related lymphedema. We think that's a really interesting group of patients because we want to know what variations of upper extremity lymphatic anatomy they have that's protecting them or preventing them from developing breast cancer-related lymphedema. And so in this study, we just looked at 16 healthy female volunteers, and I'm going to walk through what each patient goes through with this R01. So we perform an ICG lymphography on day 1 of the research visit. We have a very standardized protocol. We have 6 standard injection sites for our ICG lymphography. And we also have a very detailed algorithm where we map the arm's lymphatic anatomy. We do this in each arm. And so for each injection site, we have several questions about whether the pathway is present, how it terminates, how it courses through the arm. And this gives us a really, really detailed view of each arm's lymphatic anatomy as we see on ICG. And this is just to give you a kind of like view of what this all adds up to. We are able to create a map, and this is the anterior view of our 16 patients. We're able to create a map of their lymphatic anatomy from what we record. And so what I want to demonstrate here is that 50% of patients do demonstrate symmetry between the right and the left arms in terms of the 6 main pathways seen on ICG lymphography. However, the other 50%, the other 8 patients do demonstrate asymmetry in at least one of those 6 main pathways. Now, if we look at the anterior radial and anterior ulnar pathways, we see that they're symmetric in 100% of patients. However, if we look at the posterior radial and posterior ulnar pathways, we see that they're symmetric in 94% of patients, as well as 69% of patients, respectively. And finally, if we look at the lateral upper arm pathway and the tricipital pathway, and again, these are these compensatory or backup routes of drainage, we see that they're symmetric in 69% of participants and 81% of participants for the lateral upper arm pathway and the tricipital pathway. Now, on day one and day two of this research visit, they'll also undergo a lymphoscintigraphy. So on visit one, we will inject radiocolloid over the cephalic vein into this lateral upper arm pathway or Mascagni-Zappi pathway. That pathway drains along or courses along the cephalic vein to essentially force dye injection or the radiocolloid injection into the lateral upper arm pathway so that we can see what lymph nodes drain this collateral route of drainage. And on visit two, they'll receive an injection in the hand and the wrist, so we get a sense of the entire arm's normal drainage patterns. And if we look at the drainage patterns between the right and the left arms, the key takeaway is that 100% of patients demonstrate asymmetric functional drainage patterns between the right and the left arms. And so in conclusion, in terms of superficial lymphatic anatomy of these 6 main pathways, 50% of patients demonstrate asymmetry in their upper extremity lymphatic anatomy. And that asymmetry is highest in the upper arm, specifically the posterior upper arm and the posterior ulnar forearm. And finally, we see that functional drainage is asymmetric in 100% of patients. So we were really intrigued by these findings because earlier this year, Rosie Friedman published on swelling in early stage lymphedema and found that that swelling tends to disproportionately affect the ulnar forearm as well as the posterior upper arm. So we're seeing swelling in the region of the arm with the lowest levels of symmetry. And so we're wondering whether that asymmetry in anatomy is explaining why these parts of the arm are more vulnerable to swelling in early stage lymphedema. All right, that is the first lymphatic anatomy project. I wanted to pause and ask if anyone has any questions regarding that. Otherwise, I'm going to proceed to the next project. Okay. All right, this next project is looking at forearm drainage to the epitrochlear lymph nodes in 1,400 melanoma patients. All right, so I want to give a little bit of background. This is a paper that I come back to time and time again as a research fellow. It's actually a patient on a single patient, but again, it's a really important patient. This was a cadaveric dissection of a woman who had breast cancer, was treated with an axillary lymph node dissection, and did not develop lymphedema. Again, that's a really important patient for us because we think their anatomy is going to help us better understand what's protecting them from developing lymphedema. So Haru Swami, who's part of the LE&RN team, has done a lot of awesome anatomic dissections. And in this patient, they saw 3 changes in this arm that had an axillary lymph node dissection, but was not affected by harmed by lymphedema. The first was a major, huge enlargement of the epitrochlear lymph nodes. Now, the epitrochlear lymph nodes are in the antecubital fossa, and they represent a connection from the superficial lymphatic vessels to the deep lymphatic system. So I've talked about the posterior upper arm pathway. I've talked about the lateral upper arm pathway as compensatory routes of drainage because they drain to lymph nodes that are damaged during an axillary lymph node dissection. This is we think another route of collateralization or rerouting, which is from the superficial to deep systems. And this is where my attention has been as a research fellow. The other changes they saw was that there was obliteration or damage to the superficial lymphatic vessels. And finally, abnormal communications between the post-superficial and deep lymphatic systems. So the single cadaveric dissection, although it was one patient, really suggested that superficial to deep rerouting of drainage is an important way, an important form of collateralization that can protect a patient from developing lymphedema. So the problem is that if we know that the forearm lymphatics can drain to the epitrochlear nodes, we don't know whether there's variations between different regions of the forearm. So is the entire forearm potentially protected by drainage to the superficial to deep collateral route, or are there parts of the forearm that drain to the epitrochlear nodes more than others? That is really what we wanted to set out to explain. And so we worked with colleagues from the Alfred Nuclear Medicine and Diagnostic Ultrasound Center, the ANMU in Sydney, Australia, as well as Haru Swami from the LE&RN team, and Haley Reynolds and Thuranga Dan from the Auckland Bioengineering Institute in New Zealand. And we looked at, let me explain this database. So think about Australia. This is a population that receives a lot of UV exposure. Many patients with fair skin complexion, they have a very high burden of melanoma, unfortunately. Dr. LE&RN is a nuclear medicine physician who for several decades was recording data on melanoma patients. So they were mapping the site of these primary tumors of melanoma. And then the nuclear medicine physician would inject this tumor site with a radiocolloid, and that patient would have a lymphoscintigraphy. And that's done because melanoma metastasizes through the lymphatic system. You want to find the lymph nodes that are potentially harboring metastatic melanoma to save that patient's life. As a lymphatic researcher, that's really interesting because a single patient might not tell me too much about lymphatic anatomy, but if you start to look at hundreds or thousands of patients who have melanoma in the same region of the body, you start to get an understanding of where that skin, where that region of the body is draining. And so in this study, we looked at 1,400 forearm melanoma patients, and we divided those melanoma sites by dorsal-volar and radial ulnar to see if different parts of the forearm drain to the epitrochlear nodes more often. And what we found is that the volar forearm, melanomas of the volar forearm drain to the epitrochlear nodes in about 15% of patients, and the dorsal forearm drains to the epitrochlear nodes in about 27.5% of patients. When we divide the forearm between radial and ulnar melanomas, we find that 17.3% of radial melanomas drain to the epitrochlear nodes, and 31.3% of ulnar melanomas drain to the epitrochlear nodes. So we're seeing that the ulnar and dorsal aspects of the forearm drain to the epitrochlear nodes at a higher proportion. And if we break the forearm into 4 quadrants, so rather than looking at them separately, radial, ulnar, dorsal, volar, if we break the arm into these 4 quadrants, it's the ulnar dorsal or posterior ulnar forearm that drains to the epitrochlear nodes the most, over 32% of patients. And so in total, about over 20% of patients with a forearm melanoma demonstrated functional drainage to the epitrochlear nodes, representing possible rerouting to the deep system. And we find that epitrochlear lymph node drainage is not uniform in forearm regions. The dorsal and ulnar regions of the forearm tend to drain to the epitrochlear nodes more than the volar and radial forearm. And again, we're seeing the highest rates of epitrochlear lymph node drainage in the posterior ulnar forearm. And as I showed earlier with our paper on lymphatic symmetry, this is the region of the forearm with the highest level of asymmetry. And so it's possible that some patients with ICG patterns, superficial lymphatic patterns of their posterior ulnar forearm pathway, may not be able to drain to the epitrochlear lymph node. And so in the future, we're going to be interested in correlating ICG with lymphoscintigraphy to see if there's any association. Any questions on this project? Okay. This next project is looking at collateralization or change in the upper extremity lymphatic system after an axillary lymph node dissection. And so I'm going to make you return to this paper with me because I return to it all the time. Again, this paper demonstrated changes in the upper extremity lymphatic system after an axillary lymph node dissection. Again, grossly enlarged epitrochlear lymph nodes, abnormal communications between the superficial to deep systems, and obliteration or harm and damage to the superficial lymphatics. We're really interested in patients who've had a prior axillary lymph node dissection but did not develop lymphedema. This is another paper that I return to time and time again. This is published by Andrea Cheville, who is, I believe, now at the Mayo Clinic in Rochester, Minnesota. And this was a project funded by the Department of Defense. They looked at 32 patients. 16 of these patients had a prior sentinel lymph node biopsy, and the other 16 had a prior axillary lymph node dissection. Importantly, none of these patients developed lymphedema. So this provides us a really important insight in how that lymphatic drainage changes after an axillary lymph node dissection and in a potentially protective way. And they show described lymphatic anatomy in 3 ways. In patients with a prior axillary lymph node dissection who did not develop lymphedema, they had a mean of 2 supraclavicular lymph nodes. Patients with a sentinel lymph node biopsy had 0.4 supraclavicular lymph nodes on average. If you look at all lymph nodes draining the arms of these patients, for the patients with a prior sentinel lymph node biopsy, just over 10% of lymph nodes in total were supraclavicular lymph nodes. In contrast, in the group with prior axillary lymph node dissection, over 40% of lymph nodes draining the arm were supraclavicular lymph nodes. So we're seeing over a 4-fold increase in that proportion of lymph nodes in the supraclavicular region. And finally, if you look at a single patient and you categorize all the lymph nodes draining the arm and you categorize them where most of their lymph nodes are, for patients with a prior sentinel lymph node biopsy, only one of them had the highest number of lymph nodes in the supraclavicular region. In the axillary lymph node dissection group, 6 of those patients had the highest number of lymph nodes in the supraclavicular region. So this was really strong evidence for at least one way the lymphatic anatomy of the upper extremity can reroute or collateralize drainage to prevent the development of lymphedema. Problem, though, is that studies like this are still limited. So I've just walked through 2 studies, but it's really hard to find studies with this patient group. A prior lymph node dissection for treatment of breast cancer, but no development of lymphedema. I can maybe just a handful of studies that I found in my 8 months in this role. And so in this study, we looked at the same database from Sydney, Australia. We looked at all patients with an upper extremity, diagnosis of upper extremity melanoma. We found about 975 patients. And we then looked at their records to find patients who prior to melanoma had a breast cancer diagnosis, treatment with an axillary lymph node dissection, but no development of lymphedema. And we found several patients. So we found 22 patients. So in the end, we had two groups, a control group and a group with a prior axillary lymph node dissection. Again, no development of lymphedema, and later on they unfortunately developed melanoma. We found 3 important changes in functional drainage patterns of their upper extremity lymphatic system. The first, that in the control group, almost 100% of patients had sentinel nodes or nodes draining the arm in the level 1 axilla, and we would expect that. But in patients with a prior axillary lymph node dissection, only about 27% of patients had a level 1 axillary sentinel node. If we look at the levels 2 and 3 of the axilla, in the control group, 3% and 1% of patients had functional drainage to the levels 2 and 3 of the axilla. But in this control group of patients with a prior lymph node dissection, 27% and 32% of patients had functional drainage to these more medial groups of the axilla, levels 2 and 3. And finally, if we look at the interval nodes of the arm, the epitrochlear and brachial nodes, in the control group, 4% and 8% of patients had functional drainage to the brachial and epitrochlear nodes. In our axillary lymph node dissection, that was 32% of patients and 23% of patients. So really what we're seeing in our patients with a prior axillary lymph node dissection who did not develop lymphedema is decreased proportion of patients with level 1 sentinel nodes, an increased proportion of patients with level 2 and level 3 sentinel nodes, and an increased proportion of patients with epitrochlear and brachial nodes. So we're suggesting rerouting of lymphatic drainage to medial groups of the axilla, but also these interval nodes of the upper extremity that represent superficial to deep collateralization. So again, this study was just using lymphoscintigraphy, and the strength of our R01 grant is that we perform the same lymphoscintigraphy, but we also will have an ICG lymphography. And we think that that added dimension of lymphatic anatomy is going to provide some important insights for how the upper extremity lymphatic system can drain. Any questions on this project? Great, okay. All right, this next project is on a large animal model looking at real-time lymphatic transport. And the focus of this is actually on some key changes we've made. So I'm going to introduce the basic animal model and then talk about what small changes we've made to get it closer to use in humans. And this model has been around for quite some time. Our lab's published several papers on this model. I inherited this project. I think this project will continue on after my time. But I really want to demonstrate why we're doing this. So if a patient were to come into an emergency room with a potential heart attack, immediately you're going to order troponin, you're going to order an EKG, and right in that moment, you're going to know what the heart's function is, the extent of damage. That does not exist with lymphedema. You have to rely on disease signs, on diagnostic imaging. You have to rely on patient symptoms. And with lymphedema, there's likely a latent or subclinical course where it's going undetected. There's no sign of disease. There's no symptoms. Being able to detect lymphedema or detect changes in lymphatic function after breast cancer surgery earlier on, prior to the development of disease signs, the development of symptoms, I think is going to be a really important change to how we surveil, diagnose, and lymphedema. And so currently we do not have an ability to evaluate the degree of lymphatic function or the efficacy of certain treatments. So being able to in real time show how surgical treatment, compression, MLD, how these things are affecting the lymphatic system would be really important in real-time feedback. And again, we think that being able to show that function in real time can change how we diagnose, surveil, and treat lymphedema. So in this project, in this animal study, we have a swine, and we use 2 experimental dyes called ZW700 and ZW800. It's a technical name. All it means is that 700, that molecule, it gives off light at 700 nanometers of wavelength, and the other gives off light at 800 nanometer wavelength. It means that we can make them fluoresce at different wavelengths and view them separately. And so in this study, we've had several different groups of pigs. The first one was where we did nothing other than just inject dye on both sides. And we use a near infrared camera that can help us see how that lymph is draining through the lymphatic system. In group 2, on one side of the leg, we would remove a lymph node and the ability to show that there's no drainage on that side of the limb. We don't see any dye because that functional drainage has been destroyed. And in group 3, we remove the lymph node, and then Dr. Singhal and our clinical fellow will perform an immediate lymphatic reconstruction, or essentially replicating breast cancer surgery, removal of the lymph node, and then restoration of flow. Then we'll inject the dye, and we can actually see this dye coursing through through this newly formed lymphatic to vein pathway, this lymphovenous bypass. And we can not just show that it's patent, that is functioning and that lymph is draining into the vein, but we can actually quantify how much of this dye is draining. And this is just to show you like what this looks like while we're in the animal lab. This finger, it's very difficult to see, but we're able to see on that bottom left corner, this experimental dye course through by using a near infrared camera. And so I'm now going to talk about 2 key changes we've made to get this closer to human translation. The first one is how we deliver these fluorescent molecules. And we now use something called VAX-ID. This is a device that standardizes how we inject intradermally. And so if you do not have a lot of training, it's very easy to accidentally inject dye or ICG into the subacute fat, into the blood circulation. It's really important in the study that we are injecting dye just into the superficial lymphatics because we're just studying lymphatic function. What this device does is it controls the depth of the needle to make sure that that injection stays intradermal every time. We get an accurate dose, we get an accurate injection, we don't have to inject as much, it's user-friendly, prevents needle stick injuries, and you have to remove a small piece before you can use it. So it's not ready until the user is ready. And this is just some imaging to show between manual intradermal injections and injections with the VAX-ID, we get an increased blood formation, meaning that that injection stays right where we inject it, where we want it. And then on the right is a pig skin histology showing that when we use that device, that injection stays in the skin. We don't want it to go into the fat. And this is just a proof of concept. We also, between manual injection and VAX-ID, we get a more consistent concentration between the dyes that we inject on the right and the left sides. It's really important that we're injecting similar concentrations on both the right and the left sides because we don't, just for the sake of like the control in the study. The second change we've made is that these fluorescent molecules, we've changed how we've conjugated them, meaning that we have these small molecules that give off light, but we have to add them to a bigger carrier molecule. In the past, they were conjugated to HSA, human serum albumin, which is a human protein, and we now conjugate them or add them to PEG, polyethylene glycol. It just means that they are like attached to a different larger molecule. And we're getting more consistent blood and lymph concentration. So just an improvement in our pharmacokinetics with these 2 dyes. So in the future, we think that technology like this that can show in real-time lymphatic function is going to meet a critical unmet need for clinicians to diagnose, surveil, and treat lymphedema. And we've just made 2 key changes. Again, the use of this VAX-ID device to make our injections more reliable and improve the pharmacokinetics of our fluorescent molecules that the study is a little bit more well-controlled. Any questions on the swine model? Absolutely.
So where is it that you're actually measuring the functionality of the lymphatic vessels? Are you waiting until the dye makes it to a central part of the body and then measuring objectively?
Yeah, thank you. That's a great question. So we take blood, urine samples and imaging samples with our near infrared camera for 3 hours. So after these 2 dye injections, so again, the lymph nodes removed, we'll perform the lymphovenous bypass to restore flow. And almost immediately at that moment, we'll inject a dye. And then for the next 3 hours at different time points, we'll take blood, urine samples, and we'll also have someone from our Mass General team using the near infrared camera. We will record with the near infrared camera right over the site of the lymphovenous bypass, and we'll also record right here. So we take blood samples from a central line and a peripheral line, and we will inject on the opposite side of this peripheral line over the superficial epigastric vein. And we expose the skin with the vein, the lymphatic vessel. We find that if we were to just use the lymphatic vessel, it would maybe move too much. We make sure that what we're imaging stays very still. And so we are imaging over this, over the peripheral lymphatics and right over the site of the lymphovenous bypass for 3 hours. And then over the time, we're able to see the dye concentration, both over the lymphovenous bypass as well as over the peripheral line. And that gives us a better understanding of how this dye is transported. Also, all of this lymph makes its way back into the blood. And at a certain point, the urine turns like a very radioactive green, and that's when we know the dye has made it. The dye has been metabolized. So
can you differentiate between the two dyes once it gets to that point?
I don't believe we can. We'll have to fluoresce. Yeah.
Thank you.
Of course. Any other questions for the swine model? Okay. All right, I'm next going to talk about a project on lymphatic surgery outcomes. I just want to make sure I'm doing okay on time. Okay, great. All right, in this study, we looked at ICG lymphography patterns before and after liposuction for treatment of unilateral breast cancer-related lymphedema. And I want to give a little bit of a background. So several months ago, Valeria Bustos, who was a research fellow in our plastic surgery department and now a first-year plastic surgery resident at the University of Miami, published with Rosie Friedman, the past Jobs lymphatic research fellow, on tracking symptoms in patients who underwent a debulk or liposuction for treatment of upper and lower extremity lymphedema. And overwhelmingly, the paper showed that this surgery is great for symptom relief or symptom resolution. Debulk, anecdotally, patients will wake up crying because there's such a weight relief of weight from their limb. And so for all of these different symptoms of lymphedema, fatigue, achiness, tiredness, pain, numbness, tingling, heaviness, swelling, in upwards of 80 to 90% of patients, they're reporting resolution or improvement of these symptoms. So we absolutely know that debulk surgery is great for symptom relief. Wei Chen, who's a plastic surgeon at the Cleveland Clinic, previously published on changes in ICG patterns before and after lymphedema patients who were treated with a lymphovenous bypass or a vascularized lymph node transplant. So there's 3 major surgical treatments for lymphedema: a vascularized lymph node transplant, a lymphovenous bypass, and a debulk surgery. So in this paper, he looked at changes in ICG patterns before and after lymphovenous bypasses and vascularized lymph node transplants, and showed that patients had a reduction in the severity of their lymphedema, at least on ICG, after these 2 surgeries. The problem is that this hasn't been done for liposuction, not that we know of. So we know that liposuction for treatment of lymphedema is great for volume reduction. It's great for symptom relief and resolution, but we're not sure whether it improves or restores lymphatic function or whether it at least reduces signs of disease severity on ICG. And this case report by Nana Yamamoto, who's a plastic surgeon, this was a really interesting case report. They were replying to an article and they were talking about a patient of theirs, which was a 54-year-old woman with lower extremity lymphedema who was treated with a debulk surgery. And they were liposuction. They had received liposuction in the leg as well as the abdomen. And he noticed changes in ICG patterns that might have suggested that there was improved function after debulk surgery. So I wouldn't even call it evidence. I would just say that people are starting to think about this, what is the full benefit of a debulk surgery, aside from volume reduction and symptom relief. So in this study, we looked at 20 women with unilateral breast cancer-related lymphedema who were treated with a debulk surgery. And we recorded their preoperative ICG and their postoperative ICG. And that postoperative ICG happened at a median of 1.6 years, about 20 months after their debulk surgery. And I'm going to walk through this table with you one column at a time. But what I want you to pay attention to is the yellow row at the top. So we record ICG patterns as a disease sign, a linear sign, or not visualized. Now, there's several disease signs like splash, stardust, diffuse. Those were all condensed to disease. And we record those for 5 regions of the arm: the dorsum of the hand, the volar and dorsal forearm, the anteromedial upper arm, and the posterolateral upper arm. And in the dorsum of the hand, we see that 1 patient improved, 30% of patients worsened, meaning they had a change from linear sign to disease sign, and 65% of patients had no change, meaning that linear, not visualized, or disease sign did not change pre and post-op. In the volar forearm, we found that 20% of patients had an improvement, 1% or 5% worsened, and 75% of patients had no change in their ICG sign in the volar forearm. In the dorsal forearm, comparing pre and post-op, we found that 15% of patients had an improvement on ICG lymphography, 20% of patients had a worsening, and 65% of patients had no change. In the anteromedial upper arm, we saw that 50% of patients had an improvement in the ICG sign, and 50% of patients had no change. And in the posterolateral upper arm, 25% of patients had an improvement in the ICG sign, 10% had a worsening, and 65% of patients had no change on ICG lymphography. And I want to clarify that a change from disease to linear and not visualized to linear does not necessarily mean the same thing. So when you do not visualize something on ICG lymphography, not visualized, is not indicative of disease. Sometimes it's just that there's so much fat tissue that we cannot see deep enough to see the lymphatic vessel. So a change from not visualized to linear does not necessarily mean improvement. So I want to separate those two things out. So really our key takeaways are that in these 5 regions of the arm, there's no change in the ICG sign for 50 to 75% of patients. However, we see a worsening in the dorsum of the hand in 30% of patients. And in the anteromedial upper arm, 50% of patients demonstrate an improvement, either from disease to linear or not visualized to linear. So those 50% of patients, those 10 patients, 5 of them transition from disease sign to linear, and 5 transition from not visualized to linear. So in the future, we'll need to parse those patients out further with more patients. We're really excited by this, though, because the anteromedial upper arm represents the site where these main lymphatic collectors of the arm are coalescing and terminating into the axilla. And so seeing a change from not visualized to linear or disease to linear at this site where really the main lymphatics are coming together and then terminating into the axillary lymph nodes, we need to follow up with other types of imaging to show that this is improvement of function, but we were very excited to see an improvement to linear sign in this region of the arm. So again, this study just looked at ICG lymphography, but for these patients pre and post debulk, we also record, we have a pre and post-op lymphoscintigraphy and a pre and post-op MRI. And in the future, we're going to do our best to correlate these 3 imaging modalities, especially with lymphoscintigraphy, which can make a better argument for an increase of function after debulk surgery. Okay, any questions on the outcomes of debulk? Yes. That's a good question. I'm not sure. I anecdotally want to say yes, but I can't confidently confirm that. Okay, these next 2 research projects, I've called them assorted. These are projects I've worked on with a lot of other research fellows in the plastic surgery department. And I think they're important. They just don't fit neatly into any kind of topic. And I think the last one is a little, not the most clinically relevant, but I think something, it's what I'd like to end on, which is empowering patients, empowering lymphedema therapists. The first project I'm going to talk about is racial and ethnic representation in lymphedema treatment clinical trials. I worked on this with one of Dr. Bernard Lee's key lead research fellow, Dr. Maria. So in this study, we were interested in looking at racial and ethnic reporting in these clinical trials, particularly because we know that there are health disparities between different racial and ethnic groups. And this is, of course, a concern in any country that has a large amount of demographic diversity. And so it's really important that clinical trials are representative of the target population. It's important that different patient groups are adequately represented in these clinical trials to make sure that they're generalizable. And so the problem is that we don't really know how well these trials are reporting race and ethnicity data. And we sought to do that with a systematic review of lymphedema treatment clinical trials. And so what we know is that there are social determinants of health. The zip code often predicts a lot of your health outcomes, and these social determinants of health lead to unequal health outcomes. So we wanted to get a sense of how well represented different race and ethnic groups were in these clinical trials. So we performed a systematic review of the Medline database using PRISMA guidelines, which is a standardized way of trying to identify and screen studies. In the end, we were left with 65 studies, lymphedema treatment clinical trials. And in these 65, we found that only 9 of them reported race or ethnicity data. Of these 9 controlled clinical trials, 4 of the 9 reported race according to FDA guidelines, and 2 reported ethnicity data according to FDA guidelines. So most of these studies are not reporting this demographic data, and they're not doing it the way that the FDA would suggest. We also found that racial representation, 80% of participants in these trials were white, and 83% of participants in these trials were non-Hispanic. And so in conclusion, we find that very few of these clinical trials are reporting demographic data. And we find a low representation of certain racial and ethnic groups in these lymphedema treatment clinical trials. And so in the future, we'd like to propose that there's a increased standardization of data collection and reporting in terms of demographic data. This has been a large effort in a lot of clinical trial design outside of lymphedema as well. And we think it's important to think about strategies to not only recruit patients from diverse racial and ethnic groups, but also retain them. There are different challenges to not just finding access to these trials, but also staying in them. And so that to ensure that these studies are representative of the broader population. Okay, any questions on that study? Okay, the last study I'd like to talk about is looking at lymphedema treatment online. I was born in 1997, so whether I'm Gen Z or millennial, I don't think it matters, but I'm on my phone way too much. And when we were at a research conference in Genoa, Italy, someone took a photo of me at dinner, like scrolling on my phone. I wish I could have had that for the presentation today. But these are really popular types of, social media analyses are really popular types of studies among research fellows, particularly because they're easy to do. I think they're also really important because it's where patients are, and we need to meet patients where they are. So we looked at video-based medical information reported on YouTube and TikTok related to lymphedema treatment. So to give you a little bit of background, 60% of American adults are seeking medical information online. They're choosing where they're getting their healthcare. They're making decisions about their healthcare online based on what they're reading. And I think lymphedema is a disease that is a right target for medical misinformation, particularly because it's chronic and it has a lot of financial burdens. And increasingly, the term uses financial toxicity. So there's variable insurance coverage rates for surgical treatment as well as compression. And so understandably, patients are going to want to find options that are more affordable, find things that they think might reduce the financial burden of the disease. And increasingly among our generation, Google is no longer the most popular source search engine. It's now TikTok. So people my age now are going to TikTok more than Google. And rather than reading through sterile web pages, they're just listening to what people tell them. It's engaging, it's infographic information. And so there's a huge need to address and really understand what information lymphedema patients are finding on these social media applications. So the only analysis of lymphedema content online to date, it was an analysis of 3,000 Instagram posts related to lymphedema. They used 9 different hashtags on Instagram to find these 3,000 posts. They found that only about 20% of posts were educational, and only about 23% contained valid, accurate online or accurate medical information. And so in this project, we looked at the top 100 viewed TikTok videos and the top 100 viewed YouTube videos related to lymphedema treatment and lymphedema care. And we use 3 validated measures of medical information quality and accuracy to see what the quality of this medical information was across these platforms and across types of creators like lymphedema therapists, plastic surgeons, naturopathic doctors, media outlets, things like that. And we also developed 2 novel indexes. So with the data that we collected, we got things like likes, comments, views, subscribers. We wanted to put it into a more digestible format to show you how much engagement these videos are getting and how widely they're reaching. So our total engagement index is to show you that, and we converted these to percentages. So for every 100 views, how many patients are liking or commenting, right? How many are actually, aside from viewing it, engaging with the material? And our total reach index is per subscriber, how many views, likes, and comments are there? Meaning how far beyond the subscriber base are these videos reaching? So if we compare creators between these platforms, we see that largely on TikTok, creators are self-reported lymphedema patients and lymphedema therapists. We say non-physician healthcare provider, and that does include some other providers, but for the most part, lymphedema therapists. And on YouTube, we're really seeing a lot of lymphedema therapists, as well as healthcare organizations, especially LE&RN, Lymphatic Education Research Network, which is certainly encouraging. Now, of these 3 metrics used to assess online medical information, its quality across the board, I want you to just appreciate that the quality of online medical information is higher on YouTube for all 3 of these measures. There's a few discrepancies like healthcare organizations being comparable between YouTube and TikTok for the DISCERN guidelines, but for the most part, there's more accurate information on YouTube than TikTok. And if we look at different metrics like likes, comments, views, and subscribers, across the board, TikTok outperforms YouTube, which is unfortunate. We're finding much better quality information on YouTube videos, but TikTok, the reach is just unprecedented. You're looking at, for example, a physician on YouTube is getting 141 likes on their video. versus on TikTok, they're getting 25,000. I mean, it dwarfs the reach of these YouTube videos. Now, if we look at our two indexes, the total engagement index and the total reach index, we see that the video performance is higher on TikTok videos. So, key things like, for example, healthcare organizations on TikTok, for every 100 subscribers, about 45 people that aren't subscribed are not looking for this content are seeing it. So we're seeing that really broadly, quality of online medical information is higher on YouTube, but these TikTok videos just perform so much better. And so this is our key takeaway. And so I want to walk through like two, the actual doing this study was myself and several research fellows just watching YouTube videos and TikTok videos and scoring them. And there's two anecdotes that have stuck with me that I want to talk about. The first is cellulitis and volume reduction. This is a single creator. This is a young woman who had unilateral primary lymphedema. And in one of these videos, she has an episode of cellulitis, and she's very, very sad because she's achieved a lot of volume reduction. She's been doing great. She has an episode of cellulitis. She stopped compression. She's on antibiotics. And she says, it's really sad because this volume, this increase in limb volume I have, I'm never going to get it down again. This is my new baseline. With every episode of cellulitis, I get an irreversible increase in limb volume, and that's the smallest my limb is ever going to get. That's not true. And so for patients that are encountering that, maybe a newly diagnosed lymphedema patient, a family member of a patient, that's a very harsh outlook on an episode of cellulitis, especially if a patient's going to have several episodes of this. Often this medical misinformation is accidental. It's not deliberate. And you can almost, I'll give you the second example to make this point. For example, manual lymphatic drainage. This same patient is talking about the benefit of MLD. And she says, yes, the lymphedema therapist will massage the tissue and she'll move the lymph node in my arm, in my leg, where it needs to go. And when she's repositioned the lymph node, it's going to drain there. And then she'll move it around. And you can almost hear where that patient education was coming from, that they're moving the lymph, not the lymph node. But she doesn't have, there's an asymmetry of medical training, of healthcare knowledge. She was just trying to share the benefit of this disease, maybe some catharsis, maybe to share with other patients, not really realizing that was not accurate information. And so I think it's important we think a lot about medical misinformation, especially after like the COVID-19 pandemic and vaccinations, that it's important to keep in mind that we should empower patients. We shouldn't let them understand that it's often cathartic for them to find advocacy networks to share information about their disease and treatment, but it's really important that they're well informed, especially if they have a big platform like on TikTok. And so in the future, we think that lymphedema providers belong online. It would be really cool to, in a few days, see one of you on TikTok making videos. But I want to stress that it's not about taking up space. Sometimes it's just about sharing accurate information. You don't need to be making dozens of videos a day. Maybe just linking the Lymphatic Education Research Network or linking your local healthcare organization, the closest comprehensive lymphatic center. Things like that can do a lot to advance patient care online when patients can find these resources. So creating and sharing accurate information, counteracting medical misinformation, and of course, empowering patients and advocates to be online and share, and make sure they understand, though, that they're not healthcare providers, make sure that what they're sharing is accurate. We think there's really a big need to meet patients where they are, and I would encourage all of you as a millennial to get online and make some lymphedema videos. That's everything for me. Does anyone have any questions on those last two projects? Otherwise, I'm going to turn it over to Kathy.
So one of my colleagues, fellow lymphedema therapist at Beth Israel, Emily Muller, is not able to be here today. So I'm kind of presenting this project that we put together before we went to the international site, the international conference in Genoa about a month ago. But I'm quite familiar with it, and I picked it as one of the not lab-related research projects that we have worked on that relates to lymphedema therapy. So I thought it would be kind of interesting to take a look at the lymphatic therapy's role in optimizing edema control before lymphatic surgery. When we're thinking about outcomes from lymphatic surgery, really, how are we measuring the impact of the change in lymphatic surgery? What's that starting point? I have no disclosures to report. So the background is that oftentimes you'll see in the literature reported outcomes from surgery and volume reduction, symptom reduction, but really there is no standardized way of reporting, not only of measuring edema, but also reporting improvement after surgery. And And oftentimes we have patients who come to us, and I can recognize even some of the therapists in the room who send their patients to us, and they've had a very comprehensive course of CDT. They come in and they're pretty much ready to go. They are optimized. There's really not much else we need to do with them before they have their surgical workup. And then oftentimes we also have patients who come to us, sometimes not even having had any conservative care in the past. And they really need a course of conservative treatment before we even think about proceeding with a consult for surgery. And so we handle them a little bit differently. We take baseline measurements, and from those baseline measurements, one group of patients will go on to have further treatment, or we call it optimization, and the other group may be ready for their workup. So the problem is that there really is no standardization in how the outcomes of surgery are reported. So these patients, if we take a pre-op value of their volume and we do all this optimization and then they have the surgery and we measure the difference, we're going to see a huge difference. But how do we separate the role of that preoperative course of conservative treatment versus the role of surgery? How much can we attribute to each component of the treatment for the improvement after surgery? So what we did was go into our database of patients, and we did a retrospective review of patients who underwent surgical debulking and lymph node transplant. And we wanted to look at the limb volumes and the bioimpedance scores, as well as a quality of life scores at those points, at that initial point when they came into our clinic, and that pre-op point, and then at the post-op point. So for patients, we looked at 103 patients who had full data. 56% of the patients were optimized at the time of that initial evaluation. And then 44% of the patients really required further conservative care before they moved on to any kind of surgical treatment. Looking at the bioimpedance scores, we can see on the green, those are the patients who were ready to go, didn't need any further optimization of their lymphedema. 73% had an improvement in their bioimpedance scores, meaning a reduction in the level of extracellular fluid after their surgery. And patients who needed further treatment had a 27% improvement in their bioimpedance scores. As far as limb volume, 70% of the patients had a reduction in their limb volume, and 30% of their patients had a reduction had an increase in their limb volume before going on to surgery. Quality of life, we saw 72%, 73% improvement in quality of life scores in patients who had upper extremity lymphedema, and 27% improvement in quality score in patients with lower extremity lymphedema. And you can see the 4 dimensions. We use the LymphQOL survey, and it measures improvement in function, appearance, symptom, and mood, and their overall score. We only had 19 patients who had full data on all of those time points in their quality of life self-reported scores. So we can see that in patients who need preoperative conservative treatment, we see improvement in their overall volume, bioimpedance, and quality of life scores before they even get to the point where they need that lymphatic surgery. And if we don't separate out the effect of the conservative care from the effect of the surgical care, we're really overestimating the value of the surgical improvement, and we're underestimating or undervaluing the improvement from conservative care. So this is really important in, looking at a multidisciplinary approach to treatment and equity and reporting of surgical outcomes between centers. How do you compare, one group versus another, since several groups across the country are doing research? So it was important for this group just to, put it out there. And one of the recommendations we have is that we really should use some kind of standardized metric for measuring improvement, or at least reporting what the volume is when we first see patients, if they had some kind of improvement for conservative care, and then remeasuring again just before surgery. So we try to make sure that just before the patient goes into any kind of surgical procedure, we take another volume, bioimpedance, quality of life measurement, and that's their starting point to measure any improvement in care. It's kind of interesting because several years ago when we first started, we used to measure patients at that first visit. We asked them to come out of compression for 48 hours, and we would measure them without compression. So we really saw them at their worst, because we wanted to then take another measurement post-operatively, down the line, to look at their true outcome of surgery outside of compression. If the goal of the surgical intervention was to reduce the need for compression. We wanted to be able to compare their true starting point without compression to their postoperative starting point without compression. And one of the evolutions we've had in the workup of our patients is that we don't do that anymore. It was really causing a lot of distress unnecessarily to patients who, what do you mean you want me to stay out of compression for 48 hours? I can't do that. So we stopped doing that. And so patients remain in their compression. And as you can see, we have, almost half of 40% of our patients actually need to have some kind of optimization. And in addition to what they're coming in compression, they need some kind of optimization and further conservative care before we even can work them up for surgical intervention. So we've kind of made that evolution, but I think it's important to the whole team to value the important conservative care that lymphedema therapists do. Any questions?
I work at Western Mass, and I would be referring patients to your clinic for surgical procedures. And I would hear that the distress you were describing about having to be out of their garments for, I think it was 48 hours. Was that? And some of my patients just refused to do it. And they were like, I can't do it, because they were really nervous about it.
Yeah, so we no longer do that. So if they're afraid, we're not going to ask them to do that again. All right, so then the last presentation, we have our other two research fellows, Stephanie and Angela, going to talk a little bit about our R01 grant and the U54 grant. And we also have some handouts on the table, and they'll tell you a little bit about those.
Thank you. Hi, everyone. Thank you. Good afternoon. So my name is Stephanie Zovich, and I'm a clinical research coordinator on the Beth Israel research team. I'm also the U54 project manager. So our U54 is the multi-scale spatial mapping of the human lymphatic vessels. This is a grant that is funded by the National Institutes of Health, and it is part of a larger project called HubMap, the Human Biomolecular Atlas Program. And so this project, being funded by the NIH, allows for the development of tools and is creating a team to create a global atlas, how they describe it, of the human body at a cellular level. And so we are mapping the body at a single cell resolution. And our team, being led at BIDMC, is leading the lymphatics team. I have a little video here just from HubMap, just to explain the project a little bit more. There is audio. Is there a way to...
Tens of trillions of cells
Thank you.
organized in a fascinating system, which we only partially understand. Funded by the NIH, the Human Biomolecular Atlas Project, or HubMap, is a multidisciplinary research effort by over 200 experts in more than 50 institutions. Its goal? To create a map of the human body at single-cell resolution, a feat never accomplished before.
So this is our team. So BIDMC is leading the Lymphatic Tissue Mapping Center. And our goal is to create 3D spatial and molecular maps for lymphatics as part of this larger HubMap project. And we hope that our findings will shed a light on causes of lymphatic diseases such as lymphedema. But just to backtrack on where this started, this was a project that was worked on before I started with this research team. But the goal was to map the lymphatic system on a gross level. And it started with this 1938 textbook on the anatomy of the human lymphatic system. And here's also a little video just showing how grand this project was. Here we have a Miro map. There is a QR code there, and you will be able to access a kind of condensed version of this, all the work that the research team put into this. But we are showing you're thinking about the upper extremity, specifically looking at our R01 grant. We're thinking about the upper extremity lymphatics as it relates to breast cancer related lymphedema. So here we had mapped out the superficial and the deep lymphatics, and we're also showing, it's a grand Miro map, how it also connects to the lymphatic system of the thorax. And so if you were to look at this mirror map, it shows the entire body. And we also want to note that this is something that is ever evolving. Something that Dr. Singhal is really passionate about is just continuously learning more about the lymphatic system. And so as research goes on, things will move around, things will change, but it's fantastic that this work was put in and we have this kind of skeleton to start with. As an overview of the Tissue Mapping Center at BIDMC, again, this is the only lymphatic tissue mapping center, but it's being led here. A little overview of what I will be discussing today. There are a few more components that will come as the years go on. We're currently at the beginning of year 2 of this project. We're thinking about data collection. So we are collecting peripheral and central lymphatic channels, as well as conducting MRI scans. We also are looking at solid organs, so the uterus. We are getting uterine samples from another HubMap team at the University of Pennsylvania. And on those, we are performing 3D light microscopy. And on the lymphatic tissue, those peripheral and central tissues, we are performing single nucleus RNA sequencing and codex. And so I'll kind of go through which institutions are doing what, because it's really just within our tissue mapping center, it is a huge collaborative effort. So to start just with that collection of the lymphatic tissue of those channels, the peripheral lymphatics is being collected here by Dr. Singhal, and we have a central lymphatics being conducted at the University of Pennsylvania. So to go into the peripheral lymphatics a little bit more, that is being conducted here, we are collecting lymphatic tissue from participants who are undergoing an axillary lymph node dissection and then followed by an immediate lymphatic reconstruction. And so we have the tissue up here that is collected by Dr. Singhal in the operating room. And so this is tissue that would otherwise be discarded during the procedure. And so participants consent to us taking this discarded tissue and using it for HubMap. We've had a 9 tissue collections so far for HubMap, and they are plotted on this coordinate, specifically looking at the distance of this tissue from the axillary vein. So for HubMap, it is very important to understand the location of the tissue as it's localized in the body for this donor. We also are marking it at the 12 o'clock position, which is towards the axillary vein. And that is in order to, when we create these 3D spatial maps, we understand its orientation. So the orientation of the sample, the localization of the sample is very important when submitting the data for this tissue to HubMap. So this is the just an outline of the peripheral lymphatics collection that is being done at Beth Israel. We are also conducting MRI scans. And so the MRI scans you see up here are on healthy participants. So they come in, they've never had any lymphatic reconstruction, they never had any procedures, and they come in just to kind of get a baseline, and we're able to do these imaging on the lymphatics. And so you see on your left, that is an upper extremity lymphatics, and on the right, that is a lower extremity. So that is what is being done here, the peripheral. These scans are also being done on the central lymphatics at the University of Pennsylvania. We hope soon to also have a preoperative and postoperative MRI scan of our participants who are undergoing the axillary lymph node dissection and then the immediate lymphatic reconstruction. So we hope to do the pre-op MRI, then have the tissue collection, and then have the postoperative MRI as well. So that is also part of the MRI data that we are collecting. So this was done at Beth Israel, these 2 images, but we're also having them at University of Pennsylvania. To talk a little bit about the solid organs that we are looking at, we're looking at uterine samples, healthy human uterus lymphatic tissue. And another group within HubMap at the University of Pennsylvania is helping us, and they are sending uterine samples to the University of Southern California. And so this is a video of a 3D microscopy. And the way that this is done is at the University of Southern California, they receive this lymphatic tissue. That is then cleared, so it is drained of all liquid, and it ends up looking transparent, kind of like glass. Then a special stain is added that is specific to lymphatics, and that is how the tissue is then prepped. It is then put under a special 3D light microscope, and it is multiple images of it are taken in order to create this 3D model that we can then rotate. So it's really incredible that now we can look at a human lymphatics here in 3D. Another component, so there's a lot of amazing collaborators that are just a part of our tissue mapping center. But another component is the spatial technologies unit, and that is within Beth Israel Deaconess Medical Center. And they are receiving the peripheral, the central, and the uterine samples, and they are doing different data analyses on it. So here we just have an example of one kind of test that they would do to lymphatics. And so they section the lymphatic channel off, and they also then slice those sections into 3 sections. They run 3 different components on it. H&E is a type of stain that shows greater microscopic anatomy of a sample. We have Codex. It's similar to the 3D light sheet that I just described, but it is in 2D. And the other section is just kept for future use. So this is one type of analysis that the Spatial Technologies Unit within BI is doing on these samples. Something that is so incredible that is also very recent is that they were able to successfully conduct a single nucleus RNA sequencing on a human lymphatic channel. And they are the first to ever do this on human lymphatic channel. Something that I just want to stress is that the channel is incredibly small and there's not many cells. And so doing this type of testing is extremely difficult. But the Spatial Technologies Unit was able to develop a new method to do this kind of testing. And so they were able to successfully sequence it, which is huge. And speaking to the co-investigator, he was describing that for HubMap, it is a single donor from a single location and a single sample. And so especially for lymphatics, that makes it incredibly difficult because we only have that very, very small piece of tissue. So them being able to do this is an absolutely incredible feat. And here's our team. So the overall goal is to create these molecular and cellular maps of lymphatics for HubMap, and to learn more about the lymphatic system. So there's a lot of incredible people that come together to make this tissue mapping center possible. And I'm very grateful to be a part of this team. So thank you.
Hi, my name is Angela Chen. I'm just going to take a brief period of your time and discuss our R01 grant a little bit. James already went over what the grant entails, and I'm just going to speak about who we're recruiting for this study. So our first group of patients are completely healthy volunteers, female women who do not have breast cancer and do not have lymphedema. And so we're about halfway through recruiting this population, but we are still recruiting. And it's also a great opportunity if you're interested in participating, because you get to undergo these tests and see what your patients are doing as well. And then the most important group that we're recruiting, as James spoke about, is breast cancer survivors, these women who have undergone axillary lymph node dissection and did not develop lymphedema. So again, we're interested in what about their anatomy is different that we don't know about yet. So again, the participation includes you're examined by a physical therapist, and then you undergo the 2 days of imaging studies. So that's the ICG lymphography as well as the lymphoscintigraphy. And then you're compensated $500 for completing the study. And the QR code is very unfortunately probably not working right now. You can try, but they're undergoing maintenance with the server just for this weekend. So hopefully on Monday it works. But we are really just hoping that you keep us in mind if you have a screening program or anything, and you might have patients who meet this criteria. We would be very grateful if you sent them our way. And the flyers on the tables, there are 2 versions. They're very slightly different. One is just for the completely healthy volunteers, and the other one is for the group with the axillary lymph node dissection. All right. Are there any questions?
All right, thank you. Thank you very much to the whole research team. And, you know, some of us in this room have been around for a long, long time. Again, we started when we were 5. And it's kind of incredible because patients would always say, isn't there anything else? Isn't there anything new? Is it new research? And, you know, years doing manual lymphatic drainage and bandaging. And it's so thrilling to see all the research that's being done and at, multiple levels. Clinical research, animal research, in many different areas. And we heard this morning from, about the contributions from the LE&RN network and how much they've done for education and advocacy and trying to get research dollars allocated to lymphatic research. And we saw the presentation by Jobst, how they support our research efforts. So we have a lot of people. We're really grateful to all of this support for, advancing the knowledge of lymphatic diseases and treatment. And just wanted everybody to know how far we've come, and we're seeing an acceleration in all the research that's being done. So there's a lot of hope out there.